Good morning. Today's online class is about blood cell counts. Why is it important to know the blood cell counts? It helps because it helps in diagnosis of various disorders and its clinical management. So now coming to the overview of today's class, blood cell count as such includes various cell counts. For example, WBC count, which is also called as total leukocyte count, RBC count, platelet count, then the absolute eosinophil count, and other parameters like retic count and RBC indices. RBC indices includes MCH, MCHC, and MCV. So I'll be covering about the procedure involved and also the errors which are involved during the counting procedures. Coming to the first topic, that is WBC count, also known as total leukocyte count. WBC count or total leukocyte count estimates the total number of WBCs per cubic millimeter or microliter of blood. This can be estimated by using two methods. The first one is the visual hemocytometer and the second one is the electronic method. The first one is the manual method, the other one is the automated one. Now coming to the visual hemocytometer method. This is performed by using an improved newborn chamber and WBC pipette. Here is the NEUBAUER chamber. So you can see two ruled areas on the surface which are about 3 mm each, 3 mm into 3 mm each. When it is covered by the cover slip, depth of the chamber is going to be 0.1 mm. So we are going to use this ruled area for counting the WBCs. As you can see, there are about 9 squares with each square measuring about 1 mm into 1 mm with an area of 9 square millimeter. The central large square is divided into 25 squares, each of which is subdivided into 16 small squares. The 4 large corner squares are used for WBC count and central large square is used for RBC and platelet count. So the improved NEUBAUER chamber, when you focus it under the microscope, this is how it is going to look like. This is one ruled area on the improved NEUBAUER chamber. So you have two of them, so you can use any one. For estimation of the WBC count, we need to use WBC pipette for collection of the blood sample. So as you can see, it has a white bulb in it and certain markings. So there is a marking. The first marking is 0.5 and then is 1, and beyond the bulb there is a marking of 11. So this is how it looks under higher magnification. Now coming to the principle involved in visual hemocytometer method. So this is nothing but counting of WBCs in a calibrated chamber by diluting of the blood in 1:20 dilution with a diluent. So what is the purpose of using a diluent? So here it causes lysis of the RBCs and staining of the WBCs. Because the cell of interest here is WBCs, we need to lyse the RBCs so that it doesn't interfere in counting. Diluting fluid which is used here is nothing but Turk's fluid, which has the following composition. It has glacial acetic acid, 1% aqueous gentian violet, and distilled water. Now coming to the procedure, we need to draw anticoagulated blood or blood from the finger prick up to the mark 0.5 in the WBC pipette. Then you wipe the tip and outside of the pipette, draw the diluting fluid up to mark 11 in the WBC pipette. Once this is done, you need to mix well by rotating the pipette for 2 to 3 minutes. So this mixing is very essential to prevent any errors later. And then you need to transfer the mixture onto the counting chamber. So this is called as charging the NEUBAUER chamber. So charge the NEUBAUER chamber after discarding first 1 to 2 drops of the mixture from the WBC pipette, and then allow the cells to settle down for 2 minutes. So once this is done, then you need to count the WBCs under low power magnification in 4 large corner squares. So when you start counting the cells in the small squares, you need to count the cells which are lying on the left and the lower lines while ignoring those on its right and the upper lines, so that when you're counting the next square, you can consider them again on the left and the lower lines, so there will not be any errors. So you need to count all the WBCs which are present in those 4 large corner squares. So when you look under the microscope, this is how each square looks like, and those round structures are the ones which are WBCs. So you need to count the WBCs in all the 4 large squares. So there are certain precautions which you need to take while performing this counting. So the bench on which the chamber and the microscope is kept, it should be free of vibrations and it should not be exposed to heat. And the cover glass what we use also should be of special thickness, and it should have a perfectly flat surface. The chamber area also should be free of any air bubbles or debris, and the fluid while charging should not overflow to the mold. So all these things, if at all not performed properly, can result in certain errors. So once you charge the chamber and after counting the number of cells, we need to calculate the total leukocyte count. So now coming to the calculation, so it is done by multiplying cells counted by blood dilution and the chamber depth, and it is divided by the area of the chamber counted. So the blood dilution factor is 20 and the chamber depth is 10 and the area of the chamber counted is 4. So finally we get the equation number of the cells counted multiplied by 50. If 200, for example, if 200 WBCs are counted in 4 large squares, total count, leukocyte count per microliter will be 200 multiplied by 50, that is 10,000 per microliter. Or if you want to express it in SI units, it will be 10 into 10 to the power of 9 per liter. So once a calculate, so there can be certain technical errors. So there can be errors during the collection of the blood sample or during pipetting and also while charging the chamber. So coming to the technical errors in blood collection, so prolonged tight application of a tourniquet can lead to venous stasis, and this results in false elevation of the cell count. And also when you're collecting the finger prick sample, excessive squeezing can result in dilution of the blood with the tissue fluid. And next step of mixing of the blood with anticoagulant, if that is inadequate, again it can lead to formation of the clots in the blood sample and result in falsely low count. And non-mixing of the anticoagulated venous blood immediately before testing also can cause fairly low counts. Now coming to the pipette, if it is a dirty pipette or a improperly calibrated pipette, even that can result in certain errors. So you have to make sure that the pipettes are calibrated and it is clean. So till now we were discussing about the manual method of estimation of the WBC count. Now coming on to the electronic method. So this is nothing but the automated hematology analysis. Electronic counter is based on the principle of impedance method or light scattering technology, or it can employ both methods. In this, particles which are passing through a chamber in single file scatter the light and convert by a detector into the pulses which are proportionate to the size of the cells, which can be then counted electronically. So here again we are going to use a lysate which will lyse the red cells so as to count the WBCs. So when it comes to electronic method, there are certain advantages and disadvantages. Coming to the advantages, it's an easy and rapid method and a time-saving method, and very large number of the cells are counted rapidly, which results in high level of precision. But it is the disadvantages being it's a costly equipment and there can be calibration error, and sometimes the nucleated RBCs can be counted as leukocytes, which has to be counter checked by performing a peripheral smear and examined by a pathologist. And even for that matter, even the platelet clumps can be counted as leukocytes. These are the disadvantages of electronic method. Next, coming to the normal range for WBC count. In adults, it is going to be 4,000 to 11,000 per microliter, whereas infants, it is 10,000 to 26,000 per microliter. And in case of children under 1 year, it is 6,000 to 18,000. So causes of abnormal leukocyte count. So when there is increased leukocyte count, we term it as leukocytosis, which is seen in severe bacterial infections and then in certain malignant conditions like leukemias. Whereas decreased leukocyte count, known as leukopenia, can be seen in aplastic anemias, pancytopenia and typhoid fever. Now coming to our next topic, RBC count. So RBC count again is going to be counted in a similar way as a WBC count, but we are going to use a different pipette and the diluent. So here the RBC pipette has a red bead and it has graduations up to 101. The diluting fluid used for RBC count is, there are two varieties. One diluting fluid contains sodium citrate and formalin with 100 ml of distilled water, and the second one, which is called as Heem's fluid, contains mercury chloride, sodium sulfate in 200 ml of distilled water. So here the diluting fluid should be isotonic so that the RBCs are not lysed. Coming to the procedure, draw blood up to 0.5 mark in that RBC pipette, wipe the tip clean and draw diluting fluid up to 101 mark. Shake it for 3 minutes to ensure proper mixing. Then charge the NEUBAUER counting chamber and count the RBCs using 40x objective in the central square, which has 25 squares and which is further divided into small 80 squares. Once the counting is done, next we proceed with the calculation for RBC counts. So here again it is going to be a multiplication of cells counted by dilution factor and the chamber depth, which is divided by the area of chamber counted. And here the dilution is going to be 1 in 200 and area counted will be 1 by 5 square millimeter. So finally the equation is going to be the number of cells counted multiplied by 10,000. So this gives the total RBC count. Normal RBC count in men is 4.5 to 5.9 millions per cubic millimeter, and in women it is 3.5 to 5 millions per cubic millimeter. Coming to the abnormal RBC counts, low RBC counts is seen in anemia, whereas a high RBC count is seen in polycythemia. Next, coming to the platelet count. So here again, for platelet count, venous blood sample is used, as finger prick sample may cause clumping of the platelets. So the procedure is going to be similar as done for the RBC count. Draw blood up to the 0.5 mark in the RBC pipette, wipe the tip clean and draw diluting fluid up to 101 mark, but the diluting fluid used here will be different. It is 1% ammonium oxalate, which is again which will lyse the RBCs. Another diluting fluid which is used in Rees-Ecker method for platelet count consists of trisodium citrate, neutral formaldehyde, brilliant cressyl blue in deionized water. So once the platelets are counted in the central large square, next we proceed with the calculation. So the formula here is again going to be the same as RBC count. So we have to use the number of cells counted multiplied by 10,000. So that will give us the total platelet count. So the normal range of platelet counts varies from 1.5 to 4 lakhs per cubic millimeter. Low platelet counts is also called as thrombocytopenia. It is seen in viral infections, for example, dengue fever, aplastic anemia, and in acute or chronic idiopathic thrombocytopenic purpura. Whereas high platelet count, which is also called as thrombocytosis, is seen in myeloproliferative disorders like chronic myeloid leukemia, and also can be seen following acute hemorrhage. So till now we have discussed about the manual methods of blood cell counts. So apart from that, which is commonly used nowadays is automated analyzers. We are no longer using the manual method for cell counts. So automated analyzers again can be of two types: fully automated and semi-automated analyzers. So in semi-automated analyzers, certain procedures like mixing of the sample is performed by the technician, and then it is fed into the analyzer. Whereas automated analyzers, they require only anticoagulated blood sample. So semi-automated, some steps are performed by the technical staff. So what do you mean by automation? By automation, you're going to replace the steps which are performed by humans by using automated machines. So here the automated analyzers use multiple principles and methods such as electrical impedance technology, fluorescence, light scatter to differentiate the cells. So they give information regarding various parameters like WBC, RBC platelet counts. Then apart from that, they give information regarding the hemoglobin percentage, PCV and RBC indices. The modern ones can give information regarding the reticulocyte count also. So they can be either a 3-part differential or a 5-part differential. Depending on the type of the leukocytes, they can differentiate. So 5-part differential will give neutrophils, lymphocytes, monocytes, eosinophils and basophils, whereas 3-part you're going to get it as granulocytes, lymphocytes and monocytes. So these are the various automated cell counters by Becton, Coulter and then Celdine, and this is the one by Horiber, which is the one used in our laboratory. So as you can see, you have the instrument wherein you feed the sample, and then next to it is the computer monitor. Here you're going to feed the patient details and the results will be displayed. So once a printout is taken, this is how it looks. So upper part will contain the patient's detail, and then in the lower part you can see certain numericals, and also you have the scatter diagram and histograms. So it gives information for a like WBC, total WBC count, and then the differentials followed by the total RBC count, hemoglobin percentage, hematocrit, then the RBC indices like MCV, MCH, MCHC, red cell distribution width, platelets, and the mean platelet volume. So here when you get a printout from the automated analyzers, when it is normal, there will not be any flagging of the results. So in this next one, you can see certain parameters are flagged. So when there is flagged reports, that means it is out of the normal range. So in such situations, we need to make a peripheral smear, and it has to be examined by the pathologist and verified. If it is accurate, if it is same as the automated analyzer results, then it can be given, or if there is any variation, the reports can be mentioned as it is. So the advantages of the automated analyzer is it is the speed. It is less time consuming, and as it counts thousands of cells as compared to the usual 100 to 200 WBC by the microscopic method, it will also be a more precise method in the absence of any abnormal cell population. So now coming to the absolute eosinophil count. So this is nothing but percentage of the eosinophils multiplied by the total leukocyte count per cubic millimeter. For example, if the total leukocyte count is 8,000 per cubic millimeter and eosinophil percentage is 20%, then absolute eosinophil count is given as 1,600 per cubic millimeter, which you get by multiplying 20 by 100 by 8,000. Eosinophilia is nothing but increased eosinophils more than 600 per cubic millimeter. So which is seen in allergic diseases like bronchial asthma, then parasitic infestations like filariasis, echinococcosis, and some skin disorders like eczema. Now finally coming to the red blood cell indices. So these red blood cell indices help us in morphological classification of anemias. Most commonly used RBC indices are mean corpuscular volume, that is nothing but MCV, mean corpuscular hemoglobin, that is MCH, mean corpuscular hemoglobin concentration, that is MCHC. So erythrocyte indices can be calculated from hemoglobin concentration, PCV, and the total erythrocyte count. Coming to the mean corpuscular volume, or MCV, it is a measure of average size of the red cells, which is calculated as PCV per 100 ml of blood divided by RBC count in millions per cubic millimeter. It is expressed in femtoliter. So normal values of MCV is 80 to 100 femtoliter. If MCV is normal, they are termed as normocytic RBCs. When MCV is more than 100 femtoliter, they are termed as macrocytic RBCs, and less than 80 femtoliter, it's going to be microcytic RBCs. So normocytic RBCs can be seen in certain anemias like hemolytic anemia and aplastic anemia, whereas microcytic RBCs are seen in iron deficiency anemia, thalassemia, and anemia of chronic disorders. Similarly, macrocytic RBCs are seen in megaloblastic anemias, liver disease, and alcoholism. Next, coming to the mean corpuscular hemoglobin, that is MCH. It is nothing but average amount of the hemoglobin in a single RBC, which is expressed in picogram, which is calculated as hemoglobin in grams percent by RBC count in millions multiplied by 10. So normal value of MCH is 27 to 32 picogram. Increased MCH is seen in macrocytic anemias, and decreased MCH is seen in certain hypochromic anemias. So the next RBC indices is mean corpuscular hemoglobin concentration. This is nothing but amount of the hemoglobin expressed as percentage of the volume of the RBCs. It corresponds with the degree of hemoglobinization of red cells on a blood smear, and the normal values are 32 to 35 grams per deciliter. Again, it is going to be low in MCH is low in hypochromic RBCs. It is calculated as hemoglobin in grams percent divided by PCV per 100 ml of blood multiplied by 100. So it is one of the best index to monitor therapy for anemia, as both hemoglobin and hematocrit are considered for calculation of MCHC. So what exactly is the application of RBC indices? So it helps in classifying the anemias based on the morphological appearance. So again, like it can differentiate between the etiology of anemias. For example, in iron deficiency anemia, MCV, MCH and MCHC are going to be low, whereas in thalassemia, though MCV and MCH is low, MCHC can be normal. In megaloblastic anemia, which results from vitamin B12 or folic acid deficiency, MCV and MCH is high, whereas MCHC can be low or normal. So the RBC indices will help us in morphological classification of anemias. Next, coming to the reticulocyte count. What are reticulocytes? So these are nothing but immature non-nucleated red cells which still contain some amount of the RNA protein, because they continue to synthesize hemoglobin after the loss of nucleus. So normally the time taken by reticulocytes to mature into RBCs is approximately 1 to 2 days. So their number in the peripheral blood is a reflection of the erythropoietic activity in the bone marrow. So that is the reason why we have to estimate the reticulocyte count. So increased erythropoietic stimulus will lead to the premature release of these reticulocytes into the circulation. That is when we get to see them in increased numbers in peripheral smear. So again, for reticulocytes, there are two methods for estimation. One is the visual method and the second one is the automated method by using the automated hematology analyzers. So when it comes to visual method, the principle here is it is stained by a supravital staining, which is done on the living cells rather than the air-dried blood smears. So we need to use certain special stain like brilliant gracile blue, which can stain the RNA. So with brilliant gracile blue, the RNA is precipitated as di-RNA protein complex. Now coming to the procedure and preparation of the staining solution, we use 1% new methylene blue. And coming to the procedure, you need to take 2 to 3 drops of new methylene blue in a small test tube. Add 4 to 8 drops of patient's EDTA blood and mix thoroughly. You incubate this mixture at 37 degrees centigrade for 15 to 20 minutes. Once the incubation is completed, remix the tube contents. Place a drop of the stained blood on a clean glass slide and make a thin blood film. Then once it is dry, you need to examine it under oil immersion. So once it is examined under microscope, reticulocytes have dark blue network or granules, while RBCs will appear bluish green. So we need to select a well spread portion of the smear in which the red cells are not overlapping, and we have to count at least 1000 red cells. Now coming to the calculation of the reticulocytes in percentage, number of the reticulocytes counted by number of the red cells counted multiplied by 100, and this is expressed in percentage. So the greenish cells, what you are seeing, they are the normal RBCs, whereas the RBCs which are showing those bluish filaments or granules are the reticulocytes, which are nothing but the immature non-nucleated RBCs. So this is how it is going to look once it is stained by the brilliant crescile blue, which is nothing but a supravital staining. So we need to count the number of reticulocytes per 1000 RBCs and then express them in percentage. So the normal values for reticulocytes will be, in infants it is 2 to 6%, and in adults and children it is 0.5 to 2.5%, and absolute count of reticulocytes is going to be in the range of 25,000 to 75,000 per microliter. So with this, I'll be completing the blood cell counts, which includes the total leukocyte count, RBC count, platelet count, and reticulocyte count. Apart from that, we have covered even the red cell indices, which includes MCV, MCH, and MCHC. I hope you understood the procedure and also the errors involved in estimating these blood cell counts. Thank you.